Now we've got Mr. Jonathan Frost from Bath, who's going to talk to us about HIPEC or just hype. And you may be kind of wondering why we've put this topic on. And it's really because I was just saying that, we kind of send our patients off for all these kind of fancy treatments, and we're not quite sure what the criteria are for who's getting these treatments, what is being done in this kind of black box of surgery at the other end, and then people come back to us and we're not really quite sure what they've had. So hopefully this will be a bit of an overview as to what this is and why we're doing it. And I think these centres are now kind of popping up all over the UK. It's definitely gaining traction. So hopefully after this I'll have a better idea of exactly what it is. Thank you.
Thank you. I hope I live up to your expectations. So as Amy said, I work in Bath, and my main declaration for this talk is that we are delivering HIPEC in Bath. So although the title is HIPEC or hype, and you'd expect some balance, I'll try and deliver some balance, but I am prejudiced. So I'd be interested to know who here knows what HIPEC is. Stick your hand up. That's everyone, almost everyone? Okay. Who thinks we should be using HIPEC for ovarian cancer treatment, first-line ovarian cancer treatment? Not that many people. Okay. Who thinks we shouldn't be using it? One person. Okay. All right. So a lot of people don't know. So hopefully I've got something to do today. So I thought I'd just run through what HIPEC is, what the current evidence is, and what sort of future areas for research there are. So it's really simple. HIPEC. You do your operation for your ovarian cancer, and you remove all of the disease from the tummy, and then you put some plastic tubes in. And then you pump in hot chemotherapy that goes in and comes out and comes circulated around a machine that heats up the fluids and pumps it back in. And when the cold fluid comes out, it goes and heats it up, and et cetera, et cetera, et cetera. And you've got chemotherapy in that fluid. So it's not technically that difficult to deliver, and it's delivered, as I said, after all of the tumour, almost all of the tumour has been removed at the time of cytoreductive surgery for ovarian cancer. So all you really need is someone who's capable of doing surgery for ovarian cancer, a machine, someone to run the machine, some chemotherapy, a bit of time, and crucially some money, because it's not currently funded on the NHS, but there are a number of centres delivering it as part of their standard ovarian cancer treatment around the UK currently, and there are more and more coming online every day. You may know that it's used for pseudomyxoma, mesothelioma, colorectal cancer, and ovarian cancer, but probably some of the best evidence supporting its use is in ovarian cancer. So why would we use HIPEC in ovarian cancer? Well, it's delivering chemotherapy to the peritoneum, and as we know, ovarian cancer is a peritoneal disease. And the problems from ovarian cancer come from the disease on the peritoneum, so that the toxicity from the cancer is mainly peritoneal. And the dose you can get to the peritoneum via systemic chemo is limited, so it makes much more sense to deliver it straight to the cancer. So you can get much higher concentration of chemotherapy at the site of the disease with limited systemic uptake and limited systemic morbidity. And you can get up to sort of 21 times the concentration to the tumour itself compared with giving systemic chemotherapy. It's thought that the heat will increase the penetration of the chemotherapy at the peritoneal surface, and also increase the sensitivity of the cancer to the chemotherapy by inhibiting DNA repair. And laboratory studies have shown that the penetration of cisplatin, which is the main agent that we use, is between 1 and 3 millimeters in depth. So any residual disease after surgery should be minimal, so that the chemotherapy can get to it and can treat it. There is a precedent for giving chemotherapy directly to the peritoneum, so there are many, many studies looking at intraperitoneal chemotherapy alongside IV chemotherapy in the treatment of ovarian cancer that show a survival benefit, but that has never really got traction in Europe because of the morbidity and sort of catheter-related side effects with giving intraperitoneal chemotherapy. So I'm going to look at, first of all, at the HIPEC in the primary setting. And when I say HIPEC, I mean HIPEC and cytoreductive surgery. So if I just say HIPEC, assume that the surgery has also been done, because there's no point doing HIPEC unless you're doing the surgery. So I'm going to tell you about the 3 main phase 3 RCTs done in the primary treatment of ovarian cancer with HIPEC. I haven't got enough time to go into the kind of other trials, so I'll just focus on the main ones. And the first study I'm going to tell you about is the Dutch study. This is the OV-HIPEC study, and it's probably the most well-known. In this study, they looked at patients with FIGO stage 3 ovarian cancer, and they looked at those patients that weren't eligible for primary cytoreductive surgery. And then they randomized them to either have standard cytoreductive surgery or cytoreductive surgery with HIPEC, with the thought that the surgery would be the same in both arms. And they gave 100 milligrams per meter squared of cisplatin. The only reason I tell you these numbers is because you'll see that they're different almost in every trial that's done for 90 minutes between 40 and 41 degrees, alongside sodium thiosulfate, which is absolutely crucial in preventing renal toxicity with HIPEC. Primary endpoint was recurrent-free survival, secondary endpoints, overall survival, side effects and quality of life. So these were patients that received neoadjuvant chemotherapy, then cytoreductive surgery and HIPEC. And they found statistically significant improvement in recurrence-free survival and overall survival in the HIPEC group compared to the surgery-alone group. There was some criticism of this trial, as there's always criticism of all trials, and it seemed to be mainly coming from people who like to do a lot of primary surgery, because obviously this shows benefit in the interval surgery setting. The trial didn't really clearly define who was suitable for primary surgery, but then it's not very that easy to define who's suitable for primary surgery and who should have neoadjuvant chemotherapy. Some of the randomization took place at fairly random times before surgery, and that was mainly for logistical reasons, I think. And it wasn't terribly clear whether or not there was the same bunch of surgeons operating on both arms, both the surgery-only arm and the surgery and HIPEC arm. And these were patients all that were referred to specialist centres in the Netherlands, so there was a possible selection bias there. Of note, there was a much higher rate of stoma use in the HIPEC group compared to the surgery-alone group, which probably reflects surgeon anxiety rather than actual evidence that there's an increased risk with anastomosis in HIPEC, because they've been using anastomosis quite safely with pseudomyxoma HIPEC for quite some time. And there was a bit of an imbalance in those patients that had high-grade serous or non-high-grade serous pathologies, which you would expect to do differently in the two arms. The trial team have been quite thorough and have published a number of follow-up studies looking at whether or not their population in their trial was representative of the general population in Holland at the time. And this study looked at exactly that question, and they found that the overall survival in their control arm was very similar to the overall survival in the general population at the time the trial was running. Many of the patient characteristics quite similar as well, and this suggested that there wasn't a huge recruitment or selection bias. As it was an open label trial, they also did a central radiology review to see if there was any difference in the reporting of progression in HIPEC versus non-HIPEC group, and with central blinded radiology review, they found that the benefits seen with HIPEC persisted. They've also reported on the 10-year outcomes, so long-term survival from the trial, and again that shows that the improvements in progression-free survival and overall survival persist with time. One of the main anxieties I think medical oncologists have about HIPEC is that the patients aren't going to get other systemic therapies afterwards because of problems caused by the HIPEC. And that doesn't seem to be the case, certainly from the OV-HIPEC data. The second study that's worth mentioning is the Korean study. This looked at FIGO stage 3 or 4 epithelial ovarian cancer. And instead of just restricting it to those having neoadjuvant chemotherapy and surgery, this looked at all comers, and the decision for either primary surgery and HIPEC or neoadjuvant chemotherapy, then surgery and HIPEC was based on individual surgeon call. This was another randomized trial, and they used 75 milligrams per meter squared of cisplatin at 41.5 degrees for 90 minutes. The data from the whole of the trial didn't show any difference in recurrence-free survival or overall survival when they were looking at the primary surgery and HIPEC group and the interval surgery and HIPEC group together. But when they looked at just those that received interval surgery, they found there was a significant difference in progression-free survival and overall survival. So it seems to be the case that it hasn't been shown to work in the primary surgical setting, but it does seem to be effective in the interval setting, which is kind of exactly what you'd expect, because the patients in the interval setting are those that have proven themselves to be sensitive to the chemotherapy that we're putting into their tummies, so it would make sense that they would do better. The third phase 3 trial is the Spanish Carcinoma HIPEC trial, in which the patients had 3 cycles of systemic chemotherapy, then randomized to cytoreductive surgery or cytoreductive surgery and HIPEC. They were using 75 milligrams per meter squared, but only 60 minutes, but at 42 degrees, so half a degree more. And they used sodium thiosulfate renal protection, but they suspended this trial after the Vandriel, so the Dutch study was published because they didn't feel it was justifiable to continue, but the data they did publish looked like it showed the same benefit for recurrence-free survival and overall survival. And all 3 of those trials have been looked at in a meta-analysis and a systematic review, and this is the forest plot from that, which again shows that progression-free survival and overall survival improve with the use of HIPEC. Clearly, with any intervention, there are morbidities or potential for complications, and a number of these were reported in the various trials, and there doesn't seem to be any statistically significant difference between the rate of these complications in the surgery-only group or the surgery and HIPEC group. There are some morbidities particular to HIPEC, and I've touched upon one of them, and that is the renal toxicity. Cisplatin, kidneys really don't like cisplatin, but what you can do is give sodium thiosulfate, which is used for cyanide poisoning, at the same time as giving the cisplatin intraperitoneal chemotherapy, and that significantly reduces the risk of renal toxicity, almost completely eliminates it. There are some concerns that patients may take longer to get to their subsequent chemotherapy after having a cytoreductive surgery with HIPEC, but there's no reported difference in time to chemotherapy in the phase 3 randomized controlled trials or in much of the real-world data. And because these trials were started some time ago, we don't know what the effect of HIPEC would be with PARP inhibitor use or bevacizumab use, but the data that is available suggests that probably it's not going to affect the use of PARP inhibitors or bevacizumab, but there are trials ongoing looking at that. Another concern would be that if a patient is having HIPEC, then they might not be eligible to participate in other trials. And I think when people are writing trial protocols now, they seem to be catching up with this, and HIPEC is included in treatment options in some of the newer trials that are coming out now. But certainly there are some trials that are currently out there where having HIPEC would be an exclusion. So what about recurrent disease? Well, most patients experience peritoneal progression with their ovarian cancer, and a certain percentage of patients will be platinum sensitive when they progress. So it makes total sense to think about HIPEC and surgery in the recurrent setting. And there are 2 randomized trials, phase 3 randomized trials looking at this. The first is the Greek study, which I'm not going to spend too long on because it's quite complicated, because they used HIPEC and cytoreductive surgery in platinum sensitive and platinum resistant patients, not all of whom were completely cytoreduced. And their protocols are different to the other trials, but they did show a survival benefit with HIPEC and cytoreductive surgery. Probably the bigger and more recently published trial is the CHIPOR study. This is a randomized phase 3 trial looking at cytoreductive surgery and HIPEC in the recurrent setting. Now, because when they started this trial, we didn't have the data from the desktop study suggesting that secondary surgery was beneficial, and the standard of care was systemic chemo. I think their ethics committee made them give 6 cycles of systemic chemo before considering surgery and HIPEC. So the patients had 6 cycles of platinum-based chemotherapy. These are all platinum-sensitive patients, with or without bevacizumab. And then they were assessed if they were suitable for cytoreductive surgery. So can all the disease be resected? And then they were randomly allocated to either receiving surgery and HIPEC or just surgery. Primary endpoints: overall survival, secondary progression-free survival, morbidity, surgical outcome, quality of life, as you would expect. And there were 415 patients in this study, so it's quite a big study. All FIGO stage 3 and 4 patients. And at the time of receiving treatment, the progression-free interval for these patients was around 17 to 18 months. Interestingly, unlike the other studies, this has shown a higher morbidity in the HIPEC group, 40% versus 20%. But they didn't introduce the sodium thiosulfate until they were 75% through this trial. And much of the morbidity is related to renal toxicity or electrolyte imbalance, so that's not entirely unexpected. But there was no difference in 30-day mortality. And this probably is one of the biggest trials to date looking at HIPEC, and they found no difference in quality of life. What they did find was that there was improvement in overall survival, progression-free survival, and peritoneal-specific progression-free survival. So again, adding evidence to the use of HIPEC in ovarian cancer. So I thought it'd be helpful just to compare HIPEC and the results from the Van Driel, the Dutch study, to other interventions that we commonly use for treating patients with ovarian cancer. So if we look at HIPEC, the Kaplan-Meiers for HIPEC versus the Kaplan-Meiers for surgery versus no surgery, and surprisingly, I don't know why this study is not in any of our guidelines, but this is, I think, the only RCT that I can find that looks at patients with ovarian cancer randomized either to have surgery or not surgery, and shows obviously a benefit with surgery. But if you compare the two, the benefit with HIPEC looks comparable to the benefit you get with surgery, which is interesting. If we look at ICON 7, which looks at use of bevacizumab, again, the Kaplan-Meier for HIPEC looks quite favourable when compared to the Kaplan-Meier for bevacizumab, and we know that bevacizumab is associated with some significant toxicity. So we accept the toxicity for bevacizumab. If there is any increased toxicity with HIPEC, surely we should accept the toxicity with HIPEC as well. So what about the guidelines? This is my, I'm not sure there's a name for this, but this is my very unscientific plot of guidelines over time in relation to whether or not they say don't do it, there's no consensus supported, or should be done. And I haven't done any logistic regression analysis on this, but I can hopefully convince you that there is a trend over time with more guidelines suggesting that it's okay to give HIPEC in 2024 compared to 2018. The previous two BGCS guidelines before the last one didn't mention HIPEC at all, and the most recent one says it can be done along the lines of the NICE interventional procedure guidance, which is in appropriately specialised centres with appropriate processes for proper clinical governance. ESMO in 2018 said don't do it, and then they had a big argument in 2022, and they came up with no consensus. And there's some very opinionated people in Europe. And the NCCN guideline from the US basically says follow the Van Driel study. If they're stage 3, then you can consider using HIPEC, sodium thiosulfate, as per the Dutch protocol. There are a few unknowns. We currently dose HIPEC according to body surface area, which means that you're giving some chemotherapy into some fluid, and so the concentration of the chemotherapy is not the same in different patients. So you're giving different concentrations of chemotherapy to the tumour in quite random ways, and that doesn't really make a lot of sense, but that's just a dosing strategy that we used from the trials. And so the Dutch people are onto this, and they are doing their SysCon trial, which is looking at a concentration-based prescribing methodology so that everyone has a consistent concentration of chemotherapy in their tummies, which makes a lot more sense. The Australians are not terribly convinced that the heat makes much difference. So they're going to do a trial of, or are doing a trial of NIPEC, so normothermic intraperitoneal chemotherapy versus hypothermic intraperitoneal chemotherapy. That's a phase 1 trial that is happening at the moment, so it'll be interesting to see the results from that. Everyone you talk to has a different opinion about whether or not HIPEC should be done open or closed. It can be done in either way. You can either stitch up the tummy, as you see in the top picture there, and you make sort of a washing up bowl full of chemotherapy in theatre, and you can have someone moving it around so the chemotherapy and the heat gets to all parts of the abdomen and pelvis, which kind of makes sense because you can steer and make sure you get a consistent dose of chemotherapy or consistent heat across the abdomen. And then a lot of centres that are starting to do HIPEC now are using the closed technique, where you put some tubes in, tubes out, close the skin, and then the chemotherapy goes in, goes out. And you have less control over where the chemotherapy goes, but probably easier to get past your health and safety team than the washing up bowl full of chemotherapy in the middle of theatre. There is also some thought that the pressure with the closed technique might increase the penetration of the chemotherapy into the tissues. But I'm not sure that's actually been shown in any preclinical or clinical studies. The one thing that everyone does say when you talk to them who does a closed technique is that if you do the closed technique, you can go for lunch because you can just leave the perfusionist to run the HIPEC, whereas if you're doing the open technique, you need to have a surgeon there who's doing the washing up. So there are a number of reasons, I think, trying to be balanced again, why you should deliver HIPEC and why you perhaps shouldn't deliver HIPEC. I would say that HIPEC is probably deliverable. It's quite a straightforward procedure, technically quite a straightforward procedure, as long as you're delivering good quality ovarian cancer surgery. And so it should be deliverable in most cancer centres. There's a rationale for why it should work, and the clinical trials seem to support its use, particularly in the interval setting and possibly now in the recurrent setting. Although I think, given our sort of treatment paradigm for treating recurrent ovarian cancer has changed somewhat since that CHIPOR study was first designed, it's going to be quite difficult to figure out who should get surgery, who should get chemotherapy followed by cytoreductive surgery and HIPEC. And I think there's probably a need for a bit of sort of sit down and chat and consensus. Think about that, because I don't think we're going to get another study that's going to give us that answer. Real life data from that have been published from countries that are currently delivering HIPEC seem to support the results and the conclusions from the trials that there is a benefit. There seems to be an acceptable toxicity or morbidity profile. And importantly, the sodium thiosulfate, which is a wonder drug, as far as I can tell, it's one of those things people have just discovered and then just keeps on having uses, like aspirin and things like that, has overcome many of the renal toxicity issues. Interestingly, the sodium thiosulfate is far, far more expensive than cisplatin. Cisplatin costs probably about 15, 20 quid for HIPEC, whereas sodium thiosulfate costs a few £100s. I imagine if you did a cost efficacy analysis, given what you need is 90 minutes of theatre time, £1,000 giving set for the pump, about 15 quid's worth of chemo, and maybe a couple of hundred quid's worth of sodium thiosulfate, that I think for the overall survival benefit of around a year, I think it probably will turn out to be cost effective. Those that argue against it would say, well, it's just good quality surgery, or it's just the heat, or it's just more chemotherapy. I think the people who say it's just more chemotherapy, I think that I'd like them to start giving intravenous chemotherapy to their patients at the time of doing a cytoreductive surgery. That's not something I think I'd be particularly happy doing. There are still some ongoing concerns with regard to the quality of the studies, but there are always concerns about the quality of studies. And there are concerns that giving HIPEC will impact the patient's access to the standard treatments that we know are effective. And I think it's really, really important to keep a continuous audit in those centres that are delivering HIPEC, and we really need a national collaborative to pool that data. And certainly there is a higher stoma rate in the HIPEC study, and I think we need to be upfront with patients when we're delivering HIPEC that actually our anxiety about doing a big operation, adding 90 minutes of time and some hot chemotherapy is probably going to lead us to have a lower threshold for creating a stoma. I've talked to some people about this. I went to Lund recently and I was like, I don't understand why people aren't doing HIPEC. And so someone said, well, it's because of the post-operative adhesions. You get post-operative adhesions and you can't do further surgery. And to me, it doesn't make much sense to withhold them effective treatment because they may need surgery they may or may not be eligible for further surgery in the future. And there's some people that say it's difficult to implement. While, yes, it is difficult to convince people to put chemotherapy into the operating theatre, and it's difficult to convince trusts to pay for something that's not currently funded, actually delivering it is actually very, very straightforward. So I think in summary, I would say that there's a big thumbs up for HIPEC and interval cytoreductive surgery for FIGO stage 3 ovarian cancer, because that's where most of the evidence is. For me, it makes sense to be delivering the same treatment for those with stage 4 disease, because the thing that's going to cause people with stage 4 disease problems is the peritoneal disease. And what we see from the studies is the incidence of peritoneal recurrence is less when you give HIPEC, but there's no difference in extraperitoneal recurrence rates. So I think unless people have got very significant stage 4 disease, it seems totally reasonable to offer them HIPEC, but that's not yet universal or standard practice. And I think there probably will be a role for HIPEC in platinum-sensitive recurrence. And with regards to HIPEC in the primary settings, and when we're doing primary surgery before any chemotherapy, well, I think we need to wait for the results of these 3 trials that are ongoing that will look at that. I couldn't talk about intraperitoneal chemotherapy without mentioning the PCOS study, which is an ongoing study in the UK looking at something completely different, but it is intraperitoneal chemotherapy. It's aerosolized intraperitoneal chemotherapy for recurrent platinum-resistant ovarian cancer. And this is open currently, and we would like all centres, all units to be recruiting to this. So this could be, you could recruit patients in your units to this study and send them to a centre for the PIPAC treatment. The PIPAC is the pressurised intraperitoneal aerosolized chemotherapy. And I thought HIPEC raised anxieties and antibodies in the operating theatre because there was liquid chemotherapy. Then I suggested aerosolizing it and pressurising it, and that really wasn't very popular. But I think we got through that. So thank you very much for listening. I would just ask you now and see if we have any change. I'm going to go with the naysayers first. Who thinks we shouldn't be delivering HIPEC for same one? Haven't changed your mind. I think that means I've been balanced, right? I think that's a good thing, isn't it? And who would say that there is a role for HIPEC in the treatment of first-line treatment of ovarian cancer? I'm going to say that's more hands.
That's great. Thank you so much, Jonathan, for that very informative talk. We've just got a couple of minutes for questions.
Thank you. Are there any surgical nuances to HIPEC surgery? Because what's the rationale for the increased or potential reason for the increased stoma rates? Because why would you expect increased stoma rates in patients having HIPEC versus non-HIPEC cytoreduction?
I think so. If you go to places like Basingstoke, where they're doing lots of surgery for pseudomyxoma, they're very happy to form an anastomosis. I think because ovarian cancer surgery with HIPEC has been done in different centres now, and by the time you get to the end of your cytoreductive surgery and then you've done your HIPEC, I think there's just a general anxiety about doing an anastomosis, which I don't think is particularly founded in evidence, but it's just everyone's tired. It's been a long operation. The patient's had a long operation. Anaesthetist wants to go home. All those ancillary things that no one really likes to talk about, but we know are true.
Jonathan, we were talking about this before I reminded you that you had to go and give your talk. Tom Cecil once said to me that there's only one thing that 2 surgeons can agree on, and that's how bad the 3rd surgeon is. And you often, when you see these new things coming in, there's a lot of people trying to protect their little domains, and obviously the medical oncologists are a bit worried about surgeons giving chemotherapy because they're worried we're going to steal it off them. There are certain units who particularly proud about their ultra-radical surgery who don't have access to HIPEC and see this as a threat to them. And I have to say, since I've been sort of back into the fold of the BGCS, I think more people have rung me up about this than anything else. And I'm sure you, as you know, there'll probably be a consensus statement, and I'm sure you will be part of that. What, in your opinion, should we be doing to ensure there is a governance framework for people? This is going to start up very, very quickly in the same way that laparoscopic surgery did, robotic surgery did, mesh surgery did. What should we, as a responsible body of people, be doing to ensure that we're doing this safely and properly?
Yeah. So I think that's a really, really important point. And I think the first thing is you don't rush into doing this. It's taken us 4 years in Bath to get to the stage where we're actually delivering this. Although I said it's easy, the procedure is easy, but it's just the setup, convincing the safety and the governance all surrounding it is challenging. I think it'd be nice if there was a national data set and register of these cases, because I think that'd be really helpful, but we are not good on national data generally. Richard was going to do something with the Upshock, which would have been helpful. It was mainly focused around Richard Edmondson in Manchester was going to do something looking at the cost effectiveness, or looking at the cost of delivering HIPEC within the UK health system, that would have given us some useful data around those concerning metrics such as time to subsequent chemotherapy, access to subsequent treatments. I think as a bare minimum, we need to be recording all of those things with prospective audit, which obviously we're doing, and we should be working in our networks locally and nationally to share and pool and review that data.